Hello, everyone. We'll get started in a minute or two. I'm sure there are some people that are still connecting. Okay, it's a minute past, and I want to be respectful of everybody's time. So I think we'll get started. Thank you all for joining us. We had a pretty good response on this meeting, so I'm glad you could all join us. We're calling this meeting and what we hope will be a series of meetings with payers and other client groups. We're calling them Dialogues with WISHIN, and we really hope they are dialogues, not a lecture. We could send you a memo if we wanted to do a lecture. So we really hope we'll have a lot of give and take and exchange of ideas and questions today. You can use the chat function if you have questions or comments. You can also raise your hand if you have something to add. And we look forward to, again, engaging in a discussion with all of you. Let's go ahead, Aisling, with the slides. So our agenda today, we'll do some introductions of the WISHIN folks. And I think we have too many attendees to go through individually, but we certainly appreciate you joining us. And as Steve is suggesting in the chat, we could do intros that way from our attendees. That would be good. After we get through the preliminaries, we'll talk a bit about our transition to our new technical environment and our efforts to simplify the process by which health plans get a hold of clinical data they need for NCQA HEDIS reporting. I'll spend a little time on some issues relating to the growth of the WISHIN network through DHS pay for performance programs. And after that, we will spend most of our time, the rest of the time really, on the results of the pre-meeting survey that we sent out and having some discussion around those questions and topics. And then finally, we'll talk about what comes next. We want these meetings to be recurring meetings and continuing conversations. So we'll talk about next steps. So next slide. So I will start, and I'll have everybody else on the WISHIN team introduce themselves. I'm Joe Kahelski. I am the CEO of WISHIN. I've been here since the beginning, and once upon a time in my career, I was sitting where many of you are. I did have a job as a Medicaid contract administrator way back when, during the Clinton administration. So I remember something about, I lived the program. I know it's much different than it was now, but I do have memories of that time and understanding and of the relationship with DHS and the contract, et cetera. So to the extent that you're representing a Medicaid plan, I've been there. Go ahead, Steve.
Thanks, Joe. Steve Rotman, Chief Operating Officer at WISHIN. It's great to see so many familiar names here and looking forward to this conversation. As Joe mentioned, if you have questions, let us know. We want to answer this. We want this to be an interactive dialogue, and appreciate your participation in this conversation, and also for being a participant of the WISHIN network. Laura?
Hi, Laura Witter, Project Director. I've been with WISHIN almost 10 years now as an employee. And I've probably worked with many of you on your implementations or answering questions or trainings. So look forward to participating in this dialogue.
And I'm Matt Jago. I'm WISHIN's new Director of Population Health and Analytics. I've been with the organization for 2 months, but prior to joining WISHIN, I spent 12 years with the Wisconsin Collaborative for Healthcare Quality, where I oversaw data collection, reporting, and analytics. So I'm excited to be part of the team, and excited to be part of this dialogue and learn about different ways that we can use the information in WISH's network to support health plans and their population health efforts.
Carol.
Hi, everyone. I'm Carol Gray-Eunice. I'm Community Outreach Specialist with WISHIN. I've been with WISHIN for a year, and I've had the advantage of meeting all of you, and I'm so happy that we are finally having this dialogue, and look forward to participating.
Hi, everybody. I'm Tom Roll. Been with WISHIN for 16 months now. Welcome to the dialogue. I spent 40 years in radio doing newscasts and sports play-by-play. And as I got older, I decided I needed to learn more about health issues. So I joined the WISHIN team here.
Aisling.
I've been with WISHIN for about 2 years, and I am the executive assistant.
Okay, great. Our purpose today really is we're looking for more formal, structured engagement with clients. As I mentioned, we've collected some survey data, some survey feedback in anticipation of this meeting, and we'll talk in detail about that later on today. Our goal is to make sure that you understand where we are in our evolution, and want you to feel comfortable in suggesting ways in which we can continue to deliver value and deliver more value to you as we move forward. So this is certainly not a one-off kind of meeting. We hope to continue this conversation, as I said, and look forward to where we go from here. So next slide. I'm going to let Steve take the next 2 sections and talk about our new technical platform and data collection for NCQA. So go ahead, Steve.
All right, thanks. And next slide. So as many of you know, we've had conversations at some point, and many of you are subscribers of our newsletter, that our network is growing. We're at nearly 2,200 sites of care, about 120 hospitals. Over the past 18 to 24 months, we've contracted many new organizations to participate. Some of those have maybe partially integrated the various interfaces to provide data into the network that you can access through WISHIN Pulse or our other services. And some of those projects to onboard data is ongoing. But as it states here, we have more data types than we ever had before. The network is dynamic. The breadth and depth. So we have more clients than we ever have. We have, again, more data than we ever have. So the value that we're able to provide changes as that value equation changes, as more participants, data contributors come into the network. And we know, you know that. But in addition to the volume of data, the utilization has also grown. We're month to month, and every year as we look at the statistics, there are nearly 4,000, maybe more than 14,000 WISHIN Pulse users. And those active users, and in the data we're seeing, health plans, you all are one of a category of our highest users of the system. So the utility of the network is proving valuable. Again, we want feedback from this group of where we're meeting the needs, where there's opportunity. And we know that the more information, again, that comes into the network, we can provide additional value. So as some of the survey results indicated, there's comments about, hey, get more data. And we are working on that actively so that what we can provide helps you manage your members, drives down that cost, improves the outcomes that you're all looking for. Next slide, please. So with WISHIN 2.0, we're tagging the new technical environment that we've been talking about for quite some time as WISHIN 2.0. Currently, we're still in our legacy, our current environment, which is hosted by our partners, Health Catalyst. And that system is being fed by live data that's also being aggregated in our new system. So essentially what that means is we're feeding two environments simultaneously. So the new environment, once we go live, hopefully later this year, will include all of the data that you're experiencing today, in addition to any and all of the new data feeds that our implementation team has been onboarding for a number of months. To get to the finish line, there are a few remaining tasks, and we're categorizing those into three major milestones. Patient matching, which is moving all of our historical data through a patient matching process. So when we go live, when you're looking for a member, that member's information is being presented accurately. And that's the experience we're providing today. But with this new patient matching process, there's enhancements. So we know that some of you have brought to our attention when maybe there's an encounter that some aspect of the patient matching tied some patients together or merged. We are working to improve that process to avoid those situations. We're also managing that process. There's a manual process involved so that there's some human intervention on our team. Another key milestone is completing the movement of interfaces to the new environment and migrating that data into the new technical environment. Again, the goal with WISHIN 2.0 is your current experience enhanced. And enhanced, we'll talk about what that enhancement looks like in more detail in future meetings, or if you would like to understand what that looks like. But that's taking that historical data, making sure it's readily available when we go live. And the last milestone is transitioning our CCDA feeds into 2.0, and that will happen later in the process, near the finish line. There are a few last mile tasks that we need to do. And again, once we've fully tested and validated the systems, the functionalities, the availability of data, then we will begin the setup of users in the new system, reaching out to organizations, making sure that those authorized users still exist, and then training in the new system. And as part of that training, we'll be doing live webinars, but also recording those and doing recording snips that you can refer to or refer back to as part of your internal learning management process or internal trainings. Something that we haven't made available in the past, but we will in the future. And specific to the payer transitions, those are coming soon. We are getting close to reaching out to all of our health plan participants to migrate and stage in the new technical environment, where you'll save your member files, medication files, care plans, etc. So stand by, that is coming soon. Next slide, please. Here's a glimpse of what WISHIN 2.0, the patient dashboard or patient summary rather looks like. After you log in and after you query for a patient, it looks similar to your current experience, but we've included, as I mentioned previously, some enhancements. Some of those enhancements, based on the feedback we've received, is single click into different sources of data. One being the Wisconsin Immunization Registry. There's a single click now that launches access into there. And also alerts. So not only readmission risks, but the existence of severe allergies, documents specific to advanced care planning documents. And we've flipped the horizontal menu, the vertical menu into a horizontal menu. And the categories of data have been, we understand, maybe not saying exactly what it is that you're looking for. So we've changed that to be very explicit. If you're looking for documents, we're calling those documents here. CCDs, we are calling those CCDs, etc. Again, as we get closer to the finish line, we will be doing those trainings and recordings so that you have this at your disposal. And if you're looking for a one-on-one demo, we can also accommodate that. Next slide is another feature that we believe is long overdue, is some trending and built-in analytics to the community health record. This is one screenshot of what we'll be able to provide, is managing those with hypertension, their blood pressures, diabetics, their A1C trends. As Matt mentioned, he's new to the organization, and he is going to lead the pop health and analytics strategies of the organization. This is just the beginning of what we'll be able to do for you all. And then the next slide is the last sneak peek at WISHIN 2.0, which is a My Patients list. So those that are managing cohorts of patients will be able to view those patients in a single list. And within there, you'll be able to look at updated demographic information, last ED, last inpatient visits, again, in easy to read, easy to access dashboard. All you need to do is favorite a patient like you would favorite a song in your Amazon or Apple Music playlist. You favorite a song, it's in your list. Now you're able to view those in a consolidated view. Next slide. Okay, we already mentioned the new staff, one of the new staff members, Matt, as the Director of Pop Health and Analytics. On Laura's team, we're bringing in 2 new implementation specialists. And I would say as a positive of COVID is now we're remote. We've been able to cast a wider net where we've been able to reach out to new talent outside of the state of Wisconsin. So there's 2 new implementation specialists. One is coming from Florida and one is coming from Idaho. They both have great experience, and one particular from the Idaho HIE. So we'll be off and running when these folks come in, and soon we'll have a clone of Carol that will be helping as an outreach specialist. So if you haven't met Carol, many of you will hear from her or her colleague that will hire here in the future. And then client engagement that goes into what we've been talking about through the outreach specialists. We want to hear feedback, and we want to make this a priority for our organization. Next slide. And next slide. So DAV update. Many of you we've gone through a couple iterations of DAV and providing supplemental data. We understand the struggles you have with the chart chase, and the purpose of the data aggregator validation program, DAV, is a certification through NCQA to streamline and reduce the chart chase on both sides of the equation, on the provider side, on the payer side. Going through this DAV certification allows WISHIN to provide validated standard supplemental data that you can ingest into your HEDIS system and use for any measure that you can. We are not providing ECQM or measure specific data. This is data in aggregate data that you can bring in. So a quick review of where we've been over the past 2 years. We had a DAV certification for measure year 2021. It was our first time through the program. It went pretty well. It was very new to everybody, and the timing was not great. It still isn't great, but we certify between the months of July and December, and then mid-December we get a report of those sources that we can use. Those that had the experience of measure year 22 know that there's improvements to the program that have to happen. We felt some bumps in the road due to what was later identified as immaterial findings that led to all Epic outpatient data being unavailable as standard supplemental data. So we had to, we first pled the case to NCQA and appealed that. That appeal was denied, and began working with those health plan participants that wanted to use WISHIN as a supplemental source to find alternative ways to provide this data. Some ingested the non-certified data as non-standard. Some declined that non-standard data altogether. But there's a silver lining, and there's a lot of lessons learned that we're applying to recertification in July in just a couple months. And I'll say that NCQA just recently, maybe 2 Mondays ago, acknowledged that the findings were, again, immaterial, and that they're going to be, in their words, more lenient when they look at SNOMED. So what I'm asking them to do is memorialize what lenient means in their guide, so that when we work with you as health plans is to provide data, that you don't have to hold your breath for what's to come. We know what's coming. We have to go through the process, the primary source verification process, but we cannot put our payers, payer participants again through a validation process that comes mid-December with surprises. So we're going to do better. We're going to apply those lessons learned and work with NCQA to build something that's future-proof and beneficial to you all. Next slide.
Okay, I think maybe it's a good idea to see if there's any questions on those two things, the 2.0 or the DAV process. I'll just add that it was not pretty. We know that, and we were very surprised at the results, given that the process is supposed to be a way to confirm that the data available in the HIE or through the HIE matches the data in the source system, and that was not the issue. they NCQA made no assertion that our data was different than the data that was in the source system. It had to do with a obscure and arcane reference to SNOMED codes that they thought were a mismatch with ICD-10 codes. As Steve said, they've now essentially agreed that if they had to do it over again, they would do it differently. I think it's fair to say that that's the gist of what they said. On the other hand, they weren't willing to reconsider a past decision, and that was unfortunate. We know that a significant amount of data was missing in this time through, and we feel reasonably confident that this problem will not recur for 23. But as Steve said, we're getting a start on the next round of certification soon, and we fully expect to have better news for the next measurement year.
And
Go ahead.
Sorry, Joy. Just one more thing is that I missed is an immediate next step as part of as an outcome of DAV. What we've learned is we need to create a multi-stakeholder quality work group that Matt will lead. Laura and I will be part of, to bring together, as I mentioned, many stakeholders, various stakeholders, to understand what the value of clean or high quality and complete data, what the value of that is to all participants of the HIE. And that will commence here in the next few months. There will be an invitation being sent out soon to participate. If that comes to you and you're unable, we would ask that you would find somebody in your stead or a delegate to participate, because that is going to be one of the more important steps to ensure that population health and analytics, that's a service we can provide to you all in the future.
Okay, thank you. I'm going to move ahead to an update on the DHS P4P program, that is Pay for Performance program. Go ahead to the next slide, Ashlyn. So right now, a Pay for Performance program is in place for hospitals that participate in WISHIN. So essentially, the Medicaid program is saying that if you as a hospital participate in WISHIN, you will qualify for incentive payments from the Medicaid program in recognition of, Medicaid's belief that more data, more broad and deep data available through the statewide health information network advances the goals of the Medicaid program, allows for better outcomes, lower costs, lower administrative costs. So the current program came out of the COVID legislation that passed in the early part of 2020. And it merely said that DHS was to develop a program that provided incentives to hospitals to participate in health information exchange, and that the incentives should vary on the basis of how much data is shared. So $8 million is available to hospitals each of the 3 initial years, 21, 22, and 23. And hospitals can essentially check up to 3 boxes. The first box is ADT only. The second box is ADT plus CCDA. And the third box is ADT, CCDA, lab, path, and radiology results all combined. So that's the way they maximize their incentive. And this was a recognition not only of new participants in WISHIN, but also for existing participants. So you didn't have to be a new participant as a hospital to qualify for the incentives. And, we've seen a number of hospital systems respond to this incentive. Steve talked earlier today about the implementation work that we're doing right now for new sources of data that are not live. And this is in part related to, when we got started on the projects, because some of them are quite recent, but it's also related to the fact that we are not in a position to add new sources of data in our existing system. So we're getting all of these new participants ready on the runway for when we go live in the new system. There will be a tremendous amount of new data and new participants data in the system. I should also say that not only has this incentive program brought new hospitals into our network, it has also encouraged participating organizations that weren't maximizing the amount of data that they were sharing to fill in those gaps. So, when we go over the survey results, one of the themes that came out of that was, hey, you need more providers and you need more types of data available. We know that, that's always our goal, but wanted to mention the P4P program and the effect it's going to have on both of those asks. We're going to have a lot more data and a lot deeper data from hospitals once we go live in the new system. Next slide. I will mention that there is a provision in the governor's budget bill this year that's working its way through the legislature right now that has language that is essentially based on the hospital P4P language from a few years ago, except it makes reference to non-hospitals. So we're specifically, looking at MDs, nursing homes, home health, and local public health. So just like the language of a few years ago, it's not really prescriptive. It just says that DHS must administer a program. We would expect that the criteria will probably be a little different. Especially for some of these provider types, it's not practical or possible for them to share as many different kinds of data just because of the nature of their business. But in any event, it's not prescriptive at all about how the program will work. It's left to DHS to come up with the way it will work, and it'll probably work differently for different types of non-hospital participants. So there is money out there. It's about 21 million over the biennium, but it's not spread out evenly. That is, it's front loaded essentially because there are greater costs in the first year of participation because of implementation costs. The dollars anticipate 100% participation in all of those categories. It's unrealistic, and if we had everybody sign up, we're going to have to hire a lot more people for Laura's staff. But it's sort of meant to be as inclusive as possible. As I said, it was in the governor's budget, so that indicates that there is administration support for this kind of approach. We will see what happens in the legislative process. We will probably know in about a month whether it makes it into the final bill that both houses of the legislature sign or pass. But we're hopeful that it makes it all the way through the process. And again, this is another way to address the concern about how many organizations are in and what kind of data are they sharing. So next slide. So at this point, want to dive into the results of the survey, and we would really like your additional context, commentary, questions, comments about the results we're seeing. I'm sure everybody on this call was not personally involved in completing the survey, so it's a chance for your voice to be heard if you didn't participate in the survey. But we really want to use this data as kind of the baseline for how the topics that we talk about in the future with this group, and to really give us some guidance about how we proceed. As an earlier slide suggested, there are a lot of things that we can do in our new system. We have to have a way to evaluate the value, the technical feasibility of all the things, all the innovations that we might pursue. And these dialogues are part of that process. So it's very important that you make your voices heard as we are answering these questions and going through our process and thinking about the innovations that we might implement in the future. So let's go ahead to the first slide. Well, here are the organizations. Now, we had more than 8 responses. Generally, I think we had 14 in total, but they came from 8 organizations. So Inclusa, Chorus, formerly known as Children's, My Choice, Lakeland, Security, Community Care, Network Health, Molina. So those are the organizations that responded. There were a few, obviously, that didn't, but just for your background, that's who we heard from. Next slide. So the first question we asked was, which data do you access most often? I guess that's another way of saying which data is the most valuable, and got a variety. We offered a lot of options here, got a variety of answers, but the ones that rose to the top were member visitor encounter information and lab and pathology results. And There's a lot of other answers here. The only ones that had 0 were creating and downloading CCDAs and accessing the health exchange, which I guess that's not that surprising. But I'd welcome comments from the group about whether this is consistent with your experience with the system, or if you didn't have an opportunity to answer the survey, what about the lab and path results? What about the member visit and encounter information is helps you out in your workflow?
And I'll just add some color commentary there, Joe, that the creating and downloading network CCDA, that we know that health plans are doing that. You might conduct those activities with a different understanding of what that is, or it's a consequence of who filled out the survey. To be specific, that creating and downloading, and Laura, please jump in if I'm missing anything, or
Yeah, I'm happy to. I can
explain that differently. Yeah, please.
Yeah, I can talk to that. What that was meant to be in it probably may not have been worded the best, but that is when you create a summary, a care summary of all of the visit information in our WISHIN Pulse system. And I do see when I do our dashboarding and reports, I do see that that is a very frequent activity of many of the payers. So I think that, correct, it may have been not worded to completely mimic what the actual wording is in the functionality, or depending upon who did fill out that survey, they may not have understood that functionality. But that is one of the highest use items that I see from the payer organizations.
And that is something that will be new and improved in the new system. Steve, you can describe that.
Yeah, so in the new system, there are categories. It still functions the same, but again, enhanced. The HL7 data, the lab pathology radiology data, we would call HL7 or V2 data. In addition to, in this new system, we're parsing those provider CCDAs that is populating the community health record. And that can be used for DAV and other purposes, but that all of that discrete data will be aggregated into a single document that we're calling the super CCDA. And within the community health record, the portal, you can choose which elements of data that you want as part of that document, because we know that those documents can be very large. And if you're looking at encounters and allergies and medications, you can choose those, and that's what we'll compile and provide. Laura, anything else to add to that?
Yeah, another enhancement will be, besides the data elements, you'll be able to pick what providers you want the information from, different organizations, or what organizations you want to exclude data from. And then we have an enhancement coming. Hopefully it'll make it in our phase 1 of implementation, but if not, it'll be in our second phase. And that is to choose a date range for the materials as well. So you could have a date range for only downloading the past year's worth of data or the past 3 months worth of data.
Right. And the output is in CCDA format. So XML. And the whole idea of CCDAs is they're meant to be ingestible into a system that isn't the system of origin, right? So it's in a standardized format. And so presumably it could be mapped into a care management system or populate something else that's, that's system that use it internally. So that could be sort of seamless. And so it's a way to pull data essentially out of the system about a patient or population of patients. that you're tracking for whatever reason, for care management or other reasons.
And you will actually have a choice. You can download it as an XML document for that purpose, like Joe mentioned. Or if you're only looking for a human readable document, you can download it in an HTML format only, so that it's only a human readable document in the event that's how you wanted to store it as well. Oh, and JSON, if anybody uses that. I don't really know much about JSON, but you have that option too.
One of the things that I noticed, okay, here's a question. Can you read that one for us, Steve?
Yes, sure. So this is from Vanessa Shaw. Vanessa, I can't remember what organization, maybe Lakeland Care. In speaking with the lab items and other use, my choice, sorry. A1C data labs are something that is being looked at in depth to support members with decreasing their A1Cs over time, or so what we are looking at when in the system, also when identifying and verifying the primary care support if needed. So so what you're seeing, just to be clear, I want to make sure if we miss this. In the previous slide, we showed the trending. So you'll be able to see those A1C trends, that trending over time. But in addition to that, you'll be able to see in the labs section of the community health record, the discrete results of those, where those results came from, date and time. So that will be available to you. And then as far as like with population health and disease management, we're looking at, with Matt, one of the things we've been talking about is how can we provide a roster? How can we provide that discrete data and make it available that you can pull into your own care management systems or disease management systems? Does that help?
Yes, that helps.
Thank you.
Great.
One of the things that I noticed, I mean, I don't think any of this is all that surprising, but I noticed the care plan one down at 2, so it was one of the lower ones. But many of you, or at least some of you, probably are aware of the process we went through with DHS to implement the care plans for the SSI members, which were mandated through the contract, and it's available to use for other members. Be interested in any feedback from this group about how that's going, the extent to which it's useful or not, anything that could be improved there. We tried to come up with a standardized sort of template so it would be common across all health plans and be accessible to provider users of the system. So if there are any folks that have experience with the care plans and have something to offer, would welcome that, or we could take a deeper dive into that at a future meeting. I think there was
Hey,
one.
Joe,
Go ahead.
Hey, Joe, it's Kathy from United, and it appears you didn't get my survey, so I apologize. I
I'm
did
sorry.
fill it out. I don't know what happened. No, that's all
Yeah.
right.
Well,
check
I'm
on it.
glad you did.
Yeah. Hey, I do have a comment about the care plans, and it's more of a question.
Okay.
You know, it was quite a lift, I think, for the HMOs
Sure was.
to provide that data, and we are now like upgrading some systems, so now we have to start working with you again and testing because of that. My question is more from a perspective of who else is opening them. You know, the purpose of putting those there was to share that with primary care physicians and providers, and you know, we would be looking at them if we would get a member from another HMO.
Right.
I'm assuming other HMOs would do the same, but that's very limited. I mean, we're all very pleased with, you know, our members tend to like where they are.
Yeah.
And so my question really is that something WISHIN can evaluate to see, are they even being opened by anybody else? And if not, then, you know, maybe it's something we bring up with DHS and really investigate the value of that ongoing.
Joe, I can talk to that.
Yeah, go ahead.
Hi, this is Laura. Actually,
Hey, Laura.
hello. Actually, I have the ability to look at that and tell you who's been opening that. And I know that there are some reports that would be made available to you that will cover all of that and who's opening that. And I'll be sending those reports into your SFTP site for who's all looking at your care plans each month. So those reports will be available for you.
Now, are they available now and I've been missing them, or are they something that's going to be happening in the future?
Well, to be honest, I'm a little behind in generating those. So they'll be available very soon, and they'll be backtracking for a few months. With our transition, some of those types of reports got a little behind in my work, and I apologize for that. But I will provide those reports very soon. And I will put them in the SFTP site. There is a folder in the SFTP site that has 4 reports. There are probably some older ones out there, but I will get them all up to date within the next couple weeks.
Okay, so there are some legacy.
That's great.
reports out there.
Yes.
Okay,
All right. Thank you very much.
sure.
And then there was also a question about Epic Care Everywhere IDs. For that, I wanted to be clear on, you're wondering if you'll be able to see what the Epic Care Everywhere ID is, or be able to look at a Epic Care Everywhere ID, or I'm not entirely sure. A little bit, could I have a little more information about that question? I think that's from Courtney Murray.
So the question was,
Yeah.
will Epic Care Everywhere IDs be included in WISHIN Pulse 2.0? Currently only see IDs for Advocate Aurora.
So I guess I can elaborate a little bit more on what I think this question means. So when we get data from our Epic customers, when they send us data through regular interfaces, what we call the HL7 interfaces, that includes the ADTs, the labs, radiology, pathology, all of that data, they use their Epic ID, which is not the Care Everywhere ID. That's a totally different ID. Then when we get care summary documents from Epic customers, so those are the CCDAs, those have the Care Everywhere ID on them. And I've been working with Epic to try to reconcile those two IDs, but unfortunately, the customers have told me that their CCDAs, the care summary documents, only have the Care Everywhere ID, and their interfaces only have the Epic medical record number. So that is why you see Care Everywhere IDs in our current system for Advocate Aurora, but you don't see them for anyone else, because our Epic, not many of our other Epic customers are sending care summaries yet. In 2.0, we are currently working on implementing care summary documents, or CCDAs, for many of our other Epic customers, and they'll be implementing those directly to 2.0. And then you will see, yes, the Care Everywhere IDs for organizations like Freighter, Ascension, Children's, we're still doing the implementation, plus our new Epic customers. So then you will see both the medical record number that we have on file for that customer, plus their Care Everywhere ID. Hopefully that answered the question.
Yes, that's wonderful. Thank you.
Sure.
And then Vanessa had a follow-up. I believe this is referring to the care plans. Is that correct, Vanessa? Like to know how the providers are using this. Can we bring it to a hospital clinic? Yes. So, okay. That's a good a piece of information for us to explore with another dialogue group, and maybe we'll have some hybrid dialogue groups as we move forward. Sarah Morgan, does WISHIN have the ability to feed Care Everywhere to populate the HMO care plans? I wonder if that's a Laura question.
It's probably
Yeah.
a Laura question, but I'm thinking it might be a little bit of a different type of a. So what'll happen with our with our Epic customers is if our customer has a visit from one of the patients that has a care plan in our system, when they do a query from their Care Everywhere system into WISHIN, that care plan will be included as part of the data that goes back to those customers. So for example, if John Smith has a care plan in our system and Advocate Aurora registers John Smith for a visit, so they have an upcoming appointment with John Smith, then the Advocate Aurora system right now automatically goes to WISHIN once they've registered that patient for an appointment and requests documents that are available in the WISHIN system for that patient so they can prepare for the visit. The care plan then, if that's in there, will be included in that mix of documents. So it is available then in their Epic system as a reference for that patient. Hopefully that answered your question.
Sarah, are we in the right ballpark there?
Yes, that does. Thank you.
Right, great. All right. Other questions or comments on the data that you access most often? This is not the last time we'll talk about this topic, I'm sure.
Hi, this is
Go ahead.
Anna from United.
Hi.
I will just continue with Kathy here. But as I'm listening, I am sorry I was able only to join the last half of the meeting. As I'm listening, a lot of it has pertaining to Medicaid, and there has been some upgrades since we joined WISHIN. I wonder if you guys would be willing to do reorientation for us, focusing on the Medicare book of business.
Sure.
And the benefits to us by continue our relationship with WISHIN.
Be happy to talk about that. Yes.
Yep, that sounds good. Send me some dates.
Yes. Yep.
Thank
that
you.
would be good.
Mhm. Thank
Mhm.
you.
Okay, let's move on to the next slide, Aisling. For what purpose do you access WISHIN data? It's other side of the same coin, probably. Care management. We expected that would be probably the highest. Collection of quality data. The permitted uses for payers in the participation agreement say prior authorization, claims adjudication, care management, and collection of quality data. So those are the four explicitly enumerated permitted uses. The rest of this is, are subspecies of that, obviously. Looks like, at least among the folks that responded to the survey, the prior auth or claims adjudication piece, not really that relevant, may be a consequence of a lot of Medicaid here as well. Any comments, other context here in terms of the purposes for which you use WISHIN data? I don't think any of this is surprising. We've got somewhat small numbers here, but as what we expected to see. Okay, let's go on to the next one. Event notifications. Obviously at least nine of the folks who answered the survey know what we're talking about. Event notifications are information about a patient or a member that's on your enrollment file that has a type of encounter or discharge that is something that gets notified. Typically, it's going to be hospital inpatient or emergency department admission or discharge. In some other cases, potentially. But we can go to the next slide. We offer kind of two flavors of event notification. One that is homegrown within WISHIN, which is what we call our patient activity report. And the other being from our partners, Bamboo Health, which are providing real-time notifications and a little bit of a tool for care management associated with transitions of care. The patient activity report is a once a day report about the previous 24 hours. So it's not real time, and it doesn't have the bells and whistles that the Bamboo Health product does. So those are the two options we have at this point in terms of notification. Welcome any comments from those who are using the service or those who might find it useful, but have as yet not decided to participate. I gather that a lot of the value has to do with being able to intervene in some way when somebody is having an emergency room encounter, for example, or an inpatient admission, managing the discharge process or the transition out of inpatient care, being alerted that a member who's part of a chronic disease cohort may be at the emergency room for, related to their chronic disease. That's what I've gathered anecdotally, but would welcome some perspectives from folks who are using the notifications about how they're using them.
Hi, this is Christine Thompson with Independent Physicians Network. And we actually just had a really great conversation this morning about how valuable those pings are from Bamboo Health for our providers. Our providers are all independent and not associated with the larger health system. So having that real-time notification has been extremely valuable for them.
In terms of, being able to do the follow-up care required.
Yes, knowing what's going on with their patient and when it's happening, so that if they need to intervene, or if it's a patient that they want to get into the clinic right away after those visits, they have that opportunity and are able to put those processes in place quickly.
Others with a perspective on the notifications? Go ahead, Steve.
Sorry, Joe, I was just Christine, in those facilities, I think it's correct that we do have a single sign-on built in from the patient ping feed and stories. So in that, from the feed, that what we've explained is that's like the knock at the door, and then access to WISHIN Pulse from within the feed. It's virtually integrated. So then you see that notification, and you can click in and now see the longitudinal record. What happened during that visit? That's something, if you or other organizations on the phone are not taking advantage of, that's something that we can enable.
Well, I can definitely check with our providers to see if they have access to that.
Yeah, and really, when it's a case of an inpatient stay, you can literally watch that inpatient stay play out in real time.
Do you need to have access to WISHIN Pulse as well to have access to that information, or
That's correct? Yeah, that right. That's the community health record piece of it. So what Steve's referring to is the sort of single sign-on integration between WISHIN Pulse and the Bamboo notification system.
I think that's probably the shortcoming for us, is I believe we only have access to the Bamboo Health at this time.
Right. We can help you with that.
We can fix that. Yep.
Thank
And
you.
we've had some conversation with Mike, but that's a conversation we can take offline if that's of interest.
Definitely. Thank you.
So Steve, looks like there's a
Yes,
new
sir.
message.
So use notifications for Bamboo Health, or I'm sorry, use notifications for Bamboo Health, MH admissions. Sorry, I'm not familiar with
Mental
that.
health.
Mental health. Yeah.
I
All right.
think.
Mental health admissions. And thank you, Vanessa. And also used for our CDC review and quality. This is for SSI quality. I've been using it for. Okay. So statement there. Mental health, those organizations can participate and contribute. We do have some, but just want to fill the flag that anything 42 CFR Part 2, we can accept and share through explicit provisions and obligations that we would write into the participation agreement for downstream sharing of that data. But that's great to hear, Vanessa. Thanks for sharing.
And just for context, 42 CFR Part 2 has to do with substance abuse treatment. And that's a federal law, that's not a state law. So there are some stricter privacy restrictions around that kind of data. As Steve said, we can share it, but there's a little more paperwork to do. And I think in the past has maybe been part of the barrier for some of the behavioral health entities to participate. But we do have some. The Aurora Psych Hospital comes to mind, and Milwaukee County Behavioral Health also. So, okay, let's move on, Aisling. Would you be interested in population health analytics? If so, for which member cohorts? So, we threw out a couple of possibilities there, and this is right up Matt's alley. Would welcome any color commentary or other comments from the group here. Frequent ED users, I think that's a persistent issue across time, and totally understand that. Diabetes, hypertension, for those who check those boxes, what specifically would you be looking at? What it would be most valuable? Maybe that's a conversation for another time. There were two folks that said other, and that was hospital admits and readmissions, monitoring trends potentially with members who are on the road to diabetes, and the documented PCP for identified members was something I was curious about. And if that person is on the call today, would be interested in learning more about that. I think there was another question where the identification of a PCP or a missing PCP was something of a concern, and I wanted to explore that a little bit. Presumably that means the health plan itself is not assigning a PCP, but I wanted to understand where that concern is coming from, and what we could potentially do to address that concern.
I think that was probably me. This is Gina from Lakeland.
Hi.
Hi. So as an MCO, we're dealing with long-term care and not acute or primary care. So the PCP information that we get is not always updated.
Right.
So to see it, you would presume that it would be updated current information if it's coming from the healthcare provider themselves or the clinic.
Mm-hmm.
That would be helpful for us to see, that we could verify that what we have in our system is up to date.
And this is Laura, that information, if we get it from the healthcare provider, we do have that in our current system and will also be in our new system. And I'm happy to show you where that is, if you haven't been able to find that.
Okay, thank you.
And are we getting on enrollment files from some of the payers, Steve or Laura? Any
Well,
kind of assignment on the enrollment files?
That's the difference between our current system and our new system right now. Our current system, we will get a primary care provider, which gets returned to the payer in their patient activity reports, but we were unable to actually write that information to our current system.
Community health record, okay.
Yes. And so I know that that was a concern by organizations. Now, in our new system, we may be able to take that information and put it in our patient demographics for the primary care provider, either what the payer organization has assigned as a primary care provider, or the primary method of, or the primary person who would be the contact for that patient, so that if a provider needs to reach out to a care manager or something like that at the payer level, they can do that.
Okay. Other questions? Was there another thing in the chat, or did I miss that? Did we get them all in the chat? Uncontrolled A1C and blood pressure in population. So that was a suggestion from Sarah for population health analytics. So, so you would define or have some kind of standard definition of uncontrolled for both of those, and presumably we could generate for your members those who are over the line in each of those categories. Is what kind of, we don't have to get too far in the weeds, but what kind of frequency of update would be useful there? Or is it just more like an alert? Hey, you've got a member who has now crossed the line.
That would be great, or like a monthly report, for members that have that data available.
Right. Okay. Yeah, we have thought a little bit about the concept of generating essentially, for lack of a better term, a notification, like beyond, hey, your member's at the emergency room. Hey, your member just had a blood test and the A1C's off the chart. Something like that.
Yeah. I'd add to that also that we've been looking at, I showed the alerts, like if this is a known diabetic patient or pre-diabetes, using some pre-analytics to look at the dangers of that and how can we alert and push that information to you, or identify it in like a dashboard that here's the members that I'm managing, surfacing that information. So these are use cases that we can start exposing hopefully shortly after our go live. So that's where the value of this group will help determine what kind of use cases and build some of those examples.
And one of the things you'll see out of the box in our WISHIN 2.0 environment, and this is not going to be the total solution for what you were looking for, but it is something that you'll see right away. And then, as Steve mentioned, we'll be working with, payer organizations, and Matt will be working with them specifically for, population health analytics. But out of the box in 2.0, right on the patient, first of all, you'll have the ability to create your own dashboard of patients that you're currently managing. And then also, when you look at any of those patients, the first thing you'll see when you look at the patient's summary page is if there's an abnormal lab that's available, you'll have an alert that shows right there that an abnormal lab came in. So you'd be able to see if there was an A1C, for example, that had an abnormal flag attached to it. And then Steve also did mention, and you'll be able to see in those trending views, A1C is going to be one of the typical trends. So if the patient is getting their A1C checked, you'll be able to see the trending views for that over time. And also blood pressure is another one of those trending tables that you'd be able to see for that patient as well. So that's out of the box, but that's not the only thing we'll be planning to do. But I just wanted to say that that'll be available right away when 2.0 comes out.
Right. Yeah. Okay. Let's move on. Aisling. I don't think we have to read this stuff to you. We'll be happy to share the slides with you if you're interested, but these were more verbatims. Asked folks to articulate, what's the most important of the benefits of participating in WISHIN, and they're here, and I think I agree with them. Maybe not everybody is experiencing each of these benefits. Every organization's a little different, but maybe there's something here that might prompt you to explore a little bit, maybe some of the value that you're not experiencing but that you might be able to. So let's go ahead to the next slide. Again, more verbatims. This one, we know health equity, social determinants is something that's getting increased scrutiny. I know that DHS, I believe it was in 22, had asked, but then kind of backed off of the requirement that health plans collect SDOH screening data for their members. I don't know what the status of that. Did that come back for 23, or is that still pending? Does anybody know? Is that in the contract this year? Are you having to do screenings for your members or capture screens?
The SN, and hopefully I get the name right, the SNS HEDIS measure is out there. So that deals with food, transportation, or housing issues, as well as there are the other HEDIS measures where it's helpful, various depression, as well as the alcohol.
Okay. And Steve, can you just briefly talk about the kinds of information that are out there right now and that might be out there in the near future?
Well, we know that there is some social information in the CCDs. It's not all that comprehensive. There's the opportunity to leverage Z codes, but they have to be coded as such in the ICD-10. So we are going to be as part of the previously mentioned multi-stakeholder quality work group, and preparation for Pop Health and Analytics is a full quality assessment of the network. What's available? What could that data be used for? Daryl, we've talked at some length about using the social descriptors, social determinants type of data, and health equity, the race, ethnicity, gender, language that exists to help support those. So some of that's out there. We need to do a full assessment. Laura knows some of that stuff off the top of her head. I won't put her on the spot, but some exists. But then again, that's where we leverage that quality work group and see how we can make those efforts to improve it.
Yeah, and before we leave it behind, I wanted to, I guess I missed something from Sarah in the chat earlier. Would like to learn more about medication data, seeing multiple fills for the same medication on the same day or several days within the same week. So that presumably is the Medicaid pharmacy fill.
Correct. And we've met with DHS as well and learned that you need a magic decoding ring to really know what all of the claim numbers mean. There's something to that. So we just want to make sure we understand what everything means so that we're interpreting it correctly.
Okay.
And like the fill numbers, what that reference is, I assume that means the medication was filled and then it was a refill, but I could be wrong with that guess.
Go ahead, Laura. Go ahead.
Yeah, with the medication fill information, you're right. You do need a magic decoding ring, and I believe we have documentation that could be provided to you. I know I have a one pager about accessing medication data, but I don't know if it goes into that level of detail. But I'm happy to add that level of detail to it, so it can basically interpret that data. Just like for your example with the fill number, it's kind of interesting. The fill number starts with 0, like it's the first fill, but and then 1 means they've refilled it once, 2 means they've refilled it twice.
Okay.
So if it's 0, it's the first time. So that can get a little confusing because it's usually weird to see a 0 and a fill number.
Yeah, that sometimes made me worry that there were no refills. I wasn't ever sure what it really meant.
Yeah, so that means that is an indication of how many times they've refilled. So when it
Gotcha.
says 0, it means they've just gotten it once.
Okay.
And then after that, it goes up.
Thank you.
Sure.
Okay, we are running out of time. Appreciate everybody's comments. I think we only have a couple of more slides. This has been really useful for us. Go ahead to the next slide, Aisling. Again, verbatims. How can we do better for you to achieve your goals in the near future? We've touched on many of these. Additional data for health systems and encourage more systems to submit clinic notes. That's a big deal for us. When we're taking on new clients under the hospital P4P program, that is the one interface that is not technically being incentivized by DHS, but we have said, hey, while you're at it, include the notes, and we'll do that at no additional cost. Because we've heard over and over, and we, intuitively know that that's valuable information to have. So I don't know that anybody, Steve, has said no to that. I think they've all taken us up on that offer. So again, that stuff is going to be sitting on the runway and ready to start flowing once we move into the new system. Gain access to aggregated data for the members on our roster. Well, I think that's another way of saying analytics. Maybe not. That's the way I'm interpreting that. Data quality, Steve has talked about that, what we're planning to do to get our arms around that issue. Psych facilities such as Rogers. Rogers has not, to be just blunt, we've gotten close a couple of times reeling them in, but they've backed away each time and have thus far not responded to those incentives that are available. More providers, more alerts, we're with you. That's our core function, bringing more data and more types of data to you. So appreciate those comments. Next slide. This relates to the DAV question. I think everybody is interested in minimizing the pain of the chart chase, or just about. We talked about the process that we're going to go through for this year. Would love to talk to folks who are not taking advantage of that, but may be interested. There's time to do that for measurement year 23, and we'd be happy to talk to you about how it works. Next slide. suggested improvements to the process. Again, these are verbatims. Just a couple here. Again, we'll share the slides if you'd like to see them. Next slide. Generally, how can we do better? Ongoing education, video tutorial. We talked about the training we're going to do on the new system and making that, available essentially on demand. You don't have to necessarily attend at a specific time. Ongoing education, that's part of the reason we're doing these dialogues. So we're always helpful. It's always helpful to get the feedback, and I hope these answers change over time, because we're knocking some off the list, and maybe there will be others that surface, but appreciate that feedback. And I think we're getting to next steps on the next slide. Yes. So one more slide. We did ask about your interest in continuing these conversations and how frequently we should do that. Quarterly, 6, monthly, 5. I think as a practical matter, given that we're going to be doing a bunch of these, I think my personal opinion is quarterly is probably the most manageable for the near term. As I said earlier, we might do some ad hoc meetings where we're talking to sort of members of different dialogue groups, because ultimately we're all part of the same network. But for the moment, our plan is to proceed quarterly. We can always do ad hoc kinds of meetings, but that would be our plan. So we'd be looking at, sometime in early August probably for our next one. Not that we can't have conversations with you in between. If you have not met Carol, you need to meet Carol. She is our eyes and ears in terms of engaging with our clients. This information and this discussion has been very useful from my perspective. Hopefully it has for you as well. So I guess with a couple of minutes left, if there are any last questions or comments from folks, hopefully you found this to be useful. I think that's a yes. I'm going to take that as a yes.
I was wondering, you guys mentioned that there's several hospital systems that are going to be starting to provide more data, and understandably that's going to be held off until WISHIN 2.0 comes out. By any chance is Ascension one of those systems?
Yes.
Yay, thank you. You've made my day.
Is there anticipated timing for most of just a follow-up question, that one, for most of the major provider systems as to when they might work their way into the DAV feeds as they send in additional information?
Yeah, Daryl, it's a consequence, or it's a timing thing. So with DAV, we can certify those sources that we have data, but we can't prospectively say, hey, HSHS, for example, is coming in or they're getting close. If we don't have that data available to add to, I think it's the DSL as part of DAV, then we can't provide that as standard supplemental data, but we can provide that data as non-standard. So at the end of the year or during HEDIS season for measure year 23, we could figure out a way for that data to get to you. Again, it's just the timing. In July, we will actually, I just completed the application yesterday for the July cohort. So we'll know more who we can pull in maybe August, September.
Okay. And I guess as a follow-up to that, if there was a way off the, some of those fields such as the OID and other columns that are often included to separate, we might be interested in receiving anyway and treating as non-standard, et cetera.
We are looking at a way to separate the feeds, a feed for non-standard and a feed for standard, so that you know what you're bringing in and you don't have to slog through the data and identify sources. So that's in motion. That will be available by the time we receive our determination letter from NCQA.
Okay, appreciate it. Thank you.
You bet.
All right. Well, we are out of time. I want to sincerely thank you for spending some time with us today. We'll be following up with you about the details of our next meeting. But certainly in the meantime, reach out with any questions. Tom has asked you to do so. Again, Carol is on point for those kinds of pieces of feedback. We'll look forward to talking to you in August. Thank you.
Thanks, everyone.
Thanks all.
Thank you.
Thank you all.